So welcome then. Let's present DDP for anybody who's interested. Go ahead.
Well, thank you for the invitation, Enrique. I am always pleased when people have some interest in DDP, and I'm more than willing to summarize a bit of how it develops and its purpose and the nature of it, and the ideas about interventions that DDP utilizes. It's developed for traumatized children and their families, especially children who are traumatized in relationships, maybe in a prior home, it may be by their parents, their caregivers, when the caregivers, say in the past, had trouble with alcohol or severe marital problems, relationship problems, or it could be a trauma, relational trauma of loss, of death, or a severe injury. So whatever the relational trauma is, what people have realized over the years is that it often interferes with subsequent relationships. That if I develop a trusting relationship with somebody, or I'm working to do that, and the person doesn't if they violate my trust, if they don't meet my basic needs, if they lose interest in me, or they think I'm a bad kid or not worth loving, then I'm going to have major troubles in order to trust the next caregiver who comes along, or my teachers, or my counselors. I will have trouble trusting key people in my life. So DDP was developed for those kids because I had been trained in more of an eclectic approach that emphasized play therapy, cognitive behavioral therapy, systemic family therapy, to work as a team, developing an educational component. That's how I had developed my practice. And I realized with these kids who've been traumatized in relationships by the key people in their life, what they needed was to learn how to actually trust adults again, to be open to forming an attachment with these adults. Now, attachment, so then I started to read more about attachment theory and research. It's a dominant theory in the world of child development. There's 30,000 studies now showing that securely attached kids do better in just about every area of their social, emotional, cognitive life than kids who have insecurity in their attachment patterns, or especially better than the kids who are disorganized in their attachment patterns. So anyway, I realized I had to help these kids. The kids in relational trauma often had pretty significant attachment problems. They didn't know how to trust. They didn't rely on people, and so I started studying that and realized from the research that kids with attachment problems, in general, had trouble managing reciprocal relationships, where you give and take and you share and you're interested in each other. They just had a hard time trusting that and managing that. They also had trouble regulating their emotional states. So anger would become rage, and fear would become terror. Sadness would be despair. It'd be too extreme. Their emotions were often extreme. They also had trouble reflecting. They often didn't know what they thought, or they couldn't communicate it. They couldn't tell people what they thought and felt and wanted. They didn't have words for their inner life. So, and when there was a conflict in a relationship, they really struggled maintaining the relationship. You know, they wouldn't forgive you. They would have to do what they call payback. So conflicts were very difficult for them to resolve and to maintain a close relationship. So those became my therapeutic goals, essentially, those four key things.
So
okay, so
go ahead. Yes, and so would you say that the children who benefit the most from DDP are the people who, or the kids that suffer in their families, whether they were adopted, whether they were from foster care, or in their biological families where they had a traumatizing experience with their parents? That's correct?
That's correct. It was for traumatized kids, relational trauma kids, who then struggle in relationships within their family. So DDP was developed for those kids, but now it's also generalized. So it's also used in more traditional families. And the child doesn't have a trauma, but a child does have difficulty regulating his emotions for all kinds of reasons. And then that places a big stress on the relationship. And though the relationship, relational trauma did not cause the problems, but now it is interfering with the relationship to help the problems to resolve themselves. Because when kids have big trouble resolving their emotions, often parents lose their temper a lot, get very angry, give consequences that become harsh. And then it becomes a vicious circle, and the kid trusts less and less, and the parents are more and more furious with the child. So it can be in a traditional family without trauma as well, but it was developed for traumatized kids who are now either in a new home, a foster placement or an adoption, or in their biological home with parents who are now able to move beyond the reasons, the original reasons, like domestic violence, say, or substance misuse, move beyond that, and now are much more available as an attachment figure for the child, who will generate safety and new learning. So it's working with those families as well.
Yes. So DDP integrates different kind of models, different kind of
Correct.
theories, right?
Correct. The attachment was the sort of the fundamental basic theory in the research consistent with that. DDP tries to be consistent with that research. But a secondary theory has been intersubjectivity theory, which is about how children, how infants especially, are able to develop a sense of self that becomes organized. So attachment is sort of one dimension. Intersubjectivity is another, then, about what is the nuts and bolts of developing a relationship with your parent when you're an infant. And what some of the researchers have found is that the nuts and bolts really are that nonverbal communication that's synchronized between an infant and a parent, where the parent is communicating their experience of the infant, which is, I find you to be delightful and enjoyable and clever, without words, because infants can't talk, but the face and the voice and the gestures and the movement of the parent, well, that's all intersubjectivity, where your sense of self grows out of your relationship with your parents and other key caregivers. And so how do I utilize that with kids who never had that when they were infants, or they had it poorly? They had parents who may have been neglecting them, so they didn't respond. And the infant got a sense, I'm not very lovable. There's something wrong with me.
Yes.
So it's to utilize those interventions then that we do naturally with infants, and develop with a child who's now 7, who doesn't have any confidence that anybody's interested in him. Now, I can't convince him with words, with just a lecture or rational discussion proving that your parents do have an interest in you. I can't do it with reinforcements of appropriate behavior. That doesn't generalize the relationships, not the way we're talking about. I have to do it through communicating with a child in a way that you might with a younger child about, my goodness, how hard it is for you. A lot of emotion in my voice with empathy, conveying empathy, also to convey delight. So in therapy, the more traditional long-term model has been a neutral stance. You sort of hide your experience of the client or the child or the adult. Well, with DDP, stressing intersubjectivity and attachment, I don't hide my experience. I will get to know the child, chat with the child, engage the child in a conversation, and help the child give expression to qualities in themselves that are delightful and interesting and clever and actually enjoyable. And then communicate my experience, which helps the child to re-experience themselves in a more positive light than they did before. It seems simple, but it's not. It's a little unusual because generally we don't relate that much. With older kids, we tend to be more rational, just rational discussions.
So therapists who come into this training and they want to learn how to perform DDP, sometimes they have questions on how they will learn this, having been trained to be separate from the client, separate or maintain a distance, or advise lecture the children or lecture the parents on how the ways things should go for the therapy to progress. But in DDP, they will learn how to embody this.
Yes, they definitely will. They will learn through if this is an in-person training, we can't do it online, but when it's in person, they can learn through the trainer showing them a videotape of a treatment session with a child and a parent using this model. So they could observe the therapy, the DDP therapy. They will also learn it through some role plays. So the trainer will probably ask somebody to volunteer to be a child, another to be a parent, and they'll role play it. And they'll demonstrate to everybody how the therapist would respond when the child says, "It's none of your effing business." Well, how do I respond to that? So the role plays will really be helpful. The participants will have an opportunity in small groups to role play among themselves too, as be the therapist, the parent, the child, and they'll get feedback on that. They will get the theory. They'll get many examples of the therapist. The trainer will give examples, both the video, but also just of routine cases without seeing it. But the therapist can say, "I had this child who did this, and this was my intervention for this reason." So there'll be many practical examples of how therapists, the trainers, use DDP in their office.
Great. And also, I've been people often ask, what's the DDP view on children mental health or psychopathology? How is it approached from a DDP stance? If the child has a diagnosis for example, ADHD or other bipolar or any other things like psychopathological diagnosis.
Yes, so we're not negating that. We're not saying those diagnoses are invalid. We're saying if a child has a diagnosis like that, may it be constitutional or was born, or a certain something in his environment triggered something that now he actually qualifies with this diagnosis, then DDP would say, well, what are we going to do? How do we develop a relationship with a child who has ADHD, for example? How do we guide this child so that they can learn to organize their cognitions, organize their behavior, their emotional state in a way that's more regulated and more organized? How can we help the child to do that? Well, we're using the same principles. We will be engaging the child. DDP is based on the idea that in healthy relationships with a parent-child or between partners, there's a give and take. There's a back and forth. There's a taking turns. There's leading and following. So in DDP, with a kid with ADHD, for example, I will probably lead this child into a way of engaging me. I will take responsibility for helping his brain to stay focused on a particular topic. How will I do that? With a lot of enthusiasm, a lot of energy, a lot of nonverbal being enthralled by a certain topic, for example. I will pull his mind into a theme. And if I actively demonstrate my experience of whatever we're talking about and my interest in it and my delight in it, my being impressed by this or that, the child will probably follow me and be able to focus on this much longer than he could focus on if he were all by himself. It's interesting, we forget that babies have a terrible attention span. You know, if we were to diagnose babies, they probably all have ADHD. I mean, their attention span is very pathetic. Their impulses are they're just, babies don't do it very well. So what do parents do? When your parent is with a baby, they have that energy, they focus, they synchronize their activity with the baby. They have a lot of presence. They hold the baby's attention, and the baby can attend when a parent's interacting with them that way 5-10 times longer than if they were alone.
Wow.
So we use the same model that we do naturally with infants. And I will hold the attention of a kid with ADHD, just using that example, but I could hold the attention or the engagement of a kid who's depressed or a kid with autism. I have to do it differently because I have to respect this child's limits of their cognition right now, or limits of their ability to handle a relationship. So an autistic child, the key interactions, I'm not going to have direct eye contact very much. I'll use my peripheral vision. I'll probably not get as close as I would with another child because it might be too stimulating for this autistic child. I might, excuse me, engage in a lot of following the lead of this autistic child. And so that I am safely with him, even though he's trying to ignore me, he sees I'm synchronized with whatever he's doing. and it's safe because I'm
Yeah.
not asking anything of him. I'm just doing what he's doing.
So
And
you are co-regulating with the child. All the theory, all the practice will come to a result of the therapist being able to engage with different kinds of kids with different kind of
correct,
problems
correct.
and meet them and make them feel that they are present and they are safe and they are understood by the therapist.
Yeah,
Is this correct?
that's very correct. We call that follow, lead, follow. It's not non-directive, it's not directive. I'll follow the lead of the child, depending on how they present and the challenges they're facing in terms of the organization of their thinking, their behavior, and their emotions. I'll follow that and I'll join them. I'll synchronize with them. And then there's a good chance pretty soon we're doing it together. We're co-regulating. And I am regulated. I am organized. I can regulate my emotions. I can attend to things for a fair bit of time. So when we're synchronized that way, I am co-regulating their inner life. And I'm not doing this with power or threats or, you have to do this. I'm doing it by just inviting them into it, being sensitive to when they go off target a little bit. I accept that, notice it, wonder about it. I might join them in that. And then we'll get back to what we were doing. So yeah, DDP, it really focuses a lot on the here and now, moment to moment relationship, how it's expressed, how it's developed with the child. And all these things I'm saying with the child, I could say with the parent too, because the parent has to trust me. The parent has to be able to synchronize with me and be able to open and be vulnerable with me and talk about their challenges with the child or other areas of their life. Excuse me, I have to co-regulate their distress, because a lot of parents, when we're moving into attachment, we're moving into relationships, we got a couple issues. Number one is the attachment history of the parent, because we tend to raise our kids the way we were raised. And if our parents tended to be harsh with us, our tendency would be harsh with our own kids. Or we might say, no, I'm not going to be harsh. Then we don't quite know what the alternatives are. And some parents are firm, I'm not going to be harsh like my parents were. And they end up being way too permissive because they don't know how to set a limit without being harsh.
Exactly.
So the attachment history has to be addressed and the implications of that and how to help people with their attachment history so it doesn't impact as much and it can be able to be utilized to develop a more secure relationship with their child than they have with their parents. Also, a problem that can come up with if I'm a parent, say an adoptive parent or a foster parent, and excuse me, I'm bringing a child into my home to help them to heal and feel good about themselves and have success, and the kid rejects me. The kid says, yeah, I don't want this. You're no good. I hate you. Leave me alone. That sort of thing. Well, after a while, the most motivated, healthiest parent who may actually have a decent attachment history can sort of start shutting down and protect themselves from the rejection of the kid. Now, we know this is true, like with our partner. If our partner doesn't respond to us, it's hard to keep open and engaged with our partner. So we tend to do the same thing with a child. It may take a little longer, and we may have more patience with a child than a partner for good reason. But after a while, what a good friend of mine, a neuropsychologist and clinical psychologist, we developed the term block care, that the ability to actively care for your child who's rejecting you for weeks or months or maybe even years is very can become, the risk is it would be compromised. And I would do my job, but my heart is sort of detaching now because the pain of rejection by my child makes me protect myself. And I tend to get defensive. I may not abuse the child, I may not abandon the child, but I may just do my job.
Yeah, so it becomes like responsibility, but not affection, not engagement.
Correct. It's only an obligation.
It's only an obligation. Yes, yes,
right.
yes.
And my heart isn't there anymore. Well, if I have a traumatized kid, that's not going to be enough.
Yes, yes. And many people who have trauma have been raised by caretakers who look after them out of obligation only.
Yes,
And it's make it very, very hard for both of them, right?
yes.
Yes,
So I
yes.
have to have a lot of empathy for the caregiver who really doesn't want to do it, but it's an obligation, like a grandparent or an uncle and aunt, or, that they really, their heart isn't in it. So I have to understand where they're coming from. They didn't want to do this. They did it out of obligation. Accept that, realize that, not shame them, not make them feel horrible because their heart isn't there. But over time, once I help them to see, I get how hard it is, then I can help them see how hard it is for the child as well. They're in this together. And the child is really struggling because they were abandoned or abused or whatever by their primary caregiver. And if I have empathy for the caregiver, they are more likely to then have empathy for the child.
Yes,
And
yes, yes.
then they're more likely to say, this kid needs me, right? What can I do differently? What can I do to help him to heal and to move on?
Exactly. So there's an innate wisdom in the caregiver, whether it's the relative or the therapist, that will be able to address the children in a different way. And this is what DDP will teach them to
Yes,
find the doorways to.
yes,
Mm.
yeah. It helps us. DDP is saying we're not ignoring the behavior, but we're not going to get distracted and only see the behavior. We're going to make sense of what does it mean?
What does it
And it
mean?
usually means mistrust. It usually means I'm afraid of a relationship with you, because you're going to throw me away anyway. Once you get to know me, you won't like me because I'm a bad kid. That often means things like that. So I will then help the parent, the caregiver, myself, to see underneath the behavior to what it means, and then join the child and have what we do a lot of is having conversations with the child. We don't talk with children, we have conversations with children using a voice similar to how a storyteller uses a voice, just to go into it. My goodness, you had a hard time on Saturday. You got so angry with your dad, you swore at him. Any idea why your anger was that big? Because it was really, really big. What was that
Yeah.
about? So I want the child to start to wonder why he swore at his father.
So DDP actually builds skills in therapy.
Oh, for sure.
For empathy, on a deliberate practice, because it's very needed.
Yes.
Yeah.
Yes, yes. And we have, with the acronym is PACE,
Pace.
being playful, being accepting, having an attitude that has a playful quality to it, has a total acceptance of the child's inner life, not the behavior, obviously. Some behaviors, they punch you, you can't accept that. You have to try to manage that. Being curious without judging, what's that about? And then having empathy. This kid is, when a child has been traumatized in relationships, when they're little kids, in the relationships, especially by somebody that they were trusting and relying on, that really compromises your development. So the empathy then for the kid, and the curiosity without judgment, the acceptance, and a playful, which is sort of an optimistic light, so you don't get lost in the problems. You see the big picture more. We call that PACE. That often is an attitude then that the therapist needs, and then the therapist teaches the parents how to have an attitude like that. One of the ways is by having the same attitude toward the parents.
Yes.
And then once the attitude is there, then the child is much more likely to start to respond to this new opportunity to have a decent relationship with this person who cares about them.
Yeah. So it's a learning process for all of them.
Oh, it
together.
really is.
Yes.
Right.
Yes.
It's based on how healthy families do it. Securely attached kids, how do they do it? How do caregivers who really are able to meet the needs of their child and not be in block care, but really get satisfaction out of caregiving and do the hard work of caregiving as well, because it is hard work at times.
Yes.
So how do they maintain that? So it's to use that sort of real life model of how human beings and families are designed to
co-regulate, to engage.
Co-regulate and teach these kids not rationally, but through experience. They're good kids. They can have relationships. They can regulate their emotional states. They can sort of reflect and make sense of things. They could do those things. They can repair relationships when there's a problem. This is to show them how to do that and do it with them, and to show parents how to do it and we'll do it with them, so that I consider myself as a therapist actually to be a midwife to the process. At the end of therapy, it's not the relationship with me that is going to be the lasting ongoing thing. It's a relationship that a child now has with their parent and a parent has with the child. If I can facilitate that, I've done my job, then I could go off into the sunset. I could take a dip in the Spanish Sea.
Yes, of course, of course. That's so wonderful. And thank you very much for this presentation. Is there something, this training is only for clinicians or for specialized professionals?
It's the trainer might want a blend of, it might be primarily for a certain group, but has space for other groups too. In general, there are clinicians, there might be social workers who are very involved with traumatized kids, as they may be social worker working with foster cares. They may work in schools. Many traumatized kids are the main kids who cause problems in school, so they may work there. They may work consulting with teachers. So it's just professionals who want to take advantage of all we now know from, I actually didn't finish, attachment theory and research, inter-subjectivity theory and research, trauma theory and research, how that affects human beings when they've been traumatized in a relationship, and finally neurobiology, how the brain works when it's safe and how the brain works when it's afraid and filled with shame. Well, how do I help the brain to start changing? So the research on neurobiology has actually guided DDP as well.
Yes.
Make it practical, the practical implications of how the brain works.
Yes.
Yes,
go ahead.
If I want the child to learn how to manage their anger, for example, I can't do it with threats. I can't do that when they're afraid. I can't do it rationally, because the part of the brain that will give us the coping skills to manage anger is only active when you're safe, for example. So I have to find a way to help the child to be safe. So then when I want to teach, quote, coping skills about anger management, they'll be receptive to it. So I got to learn how to do that.
Yes.
And again, it's how I help. My template is, how do I help babies and toddlers and 3-year-olds and 4-year-olds? How do I help them to be safe? Because that's when the healthy kids are learning all that important stuff in those first 3-4 years. And these kids are a bit late, but they can still learn it as long as I can adapt my approach to them. So there's more similarities with how I would approach a healthy 3-year-old or a healthy 4-year-old.
Yeah, so basically it's creating that safety for the communication to be able to happen.
Yeah.
And it's like polyvagal also informed.
Oh, for sure. Yeah, that's one. The neurobiology is so rich and there's so much. And one sort of pocket of knowledge is the polyvagal theory, which certainly contributes to it. It's not the only bit that's important, but that's one bit in terms of how to help people be safe, because when they're safe, they're open and engaged with other people. So then they can be influenced and they can influence other people. When they're defensive, they're only concerned about safety, and they're not really open to learning from other people unless it will be something they need for safety.
And those DDP also include research from like Alan Shore, right brain.
Oh, for sure. Yeah. Yeah, the nonverbal communication. The conversations, as Shore said a number of years ago, therapy is not a talking cure, it's a conversation cure. It's how do you have conversations with kids who don't know how to have conversations, to hold their interests, hold their energy, hold their motivation, so they actually develop the skills to have conversations with people.
Exactly. So very rich. And do the people also learn how to deal with the expectations, like in schools or centers, to discipline the children or to punish them? Do they also learn how to transmit this DDP stance to a wider community?
Well, we certainly have those skills, and sometimes we do trainings just for a school, for example, just for educators. If the majority of people in the training are therapists, social workers, it probably won't focus on education as much. It won't be ignored, but that won't be the primary focus on school management. But the same interventions, and I'm sure I would give examples of how this could apply in a school. The same issues, and a school may have big discipline issues. Well, yeah, so do parents. So do foster care, so do traumatized kids. They have big discipline issues. So we don't ignore that. We can't ignore that. We have to help the kid develop enough self-regulation so he can be social,
So you go back to the foundation of behavior.
It goes back to the foundation, because a lot of the kids, like who act out in schools, when you sit and chat with them and they're honest with you, they are convinced that nobody likes them there. They're convinced they're just bad kids. They're convinced they're stupid, they're selfish, they're mean, they're lazy. That comes from within them. It doesn't come from the teachers, but that's what they're bringing to the school. And then they're going to act that out. They're going to demonstrate, you're wasting your time. I can't learn this stuff. I'm not worth it. I'm a bad kid. I'm selfish. That's how they act. They can't say that, but that's what's driving their behavior.
Exactly.
So then when I say we have to correct their behavior, yes, we do. But if we just say cut that out, or you lose a privilege, or I'll give you this incentive if you do it right, that often isn't enough.
Yeah,
and that's
it won't reach the deeper places in them.
It won't, right? It won't reach the relational trauma that caused the challenges. They cause the behavior in the first. So we have to enable them to develop relationships with people,
yes,
including teachers.
Of course. Yes, so paramount, and how valued relationships are even in these therapeutic settings, and how relevant this model DDP, dyadic developmental psychotherapy, brings. It's like an actualizing the children to their potential and to their to their self, to their essence, bringing them to where they can actually be to thrive, rather than being stuck in a loop of their own trauma. Yeah, amazing.
And to help their caregivers be on the same journey with them, so they're more proud of themselves. They thrive as caregivers. They can see the impact they're having on very troubled kids, and they feel great inside.
Yes, that's very moving to be able to be part of the journey of anybody going through this. Yes.
Yeah.
Thank you. And so DDP starts with a level 1, and then they are able to do level 2, which is more sophisticated or deepening.
Yeah, right. It's a deepening. It builds on level 1, and what you're learning in level 1. Level 2, we encourage people to wait at least 6 months before you do level 2, because if you see the value of DDP and you're practicing in your work, then you, in level 2, you bring back your experience. And I'm struggling with this. I don't understand this. So it's more practical even than level 1. They're encouraged, if they want and are able, they have permission to show a part of a video of a treatment session to get feedback on that. Yeah, it's based on what they learn in 1 in a deeper way, more practical way.
Okay, perfect. And then they can apply for certification, right? That's
to be certified or accredited, that would come next. That would be a very individual practicum where they work with one of the DDP consultants and show videos of their treatment sessions to a consultant, and then get feedback on it, and then you get ongoing supervision in DDP. So it's a minimum of 10 sessions. Often it takes like 1 session a year. You get feedback, give or take, but it's the minimum is 10. Sometimes it's 12, 15 sessions when the consultant and a second opinion person, another consultant, believes you have the basic skills of DDP. So then you become accredited or certified. So if you go on our website, ddpnetwork.org, you'll see a list. You can find a list of all the people who are now certified practitioners in DDP throughout the world. They're all over the place.
Yes. And now we hope to develop a Spanish cohort, Spanish-speaking
cohort.
Oh,
wonderful. Yeah.
Yes.
If I had one regret, it's that DDP is primarily English-speaking.
Yes,
That's
yes.
great.
We're going to try to bring it into Spanish language. So
Oh my
we
gosh,
invite,
I think in many ways Spanish language is more conducive to DDP than the English language. I think
yeah,
there's probably more rhythm to it, more melody quality to it, more of a emotional component is more easy to express it in Spanish, I believe.
yes. My sense is that clinicians in Spain and in Latin America will begin to enjoy and flavor the deep work that can transform the life of children and their caregivers and the clinician themselves
Well, I hope
by
so.
learning the steps of DDP. Yes, yes. And can you share a bit about where DDP has been applied? I think it's been applied in major charities in Great Britain or agencies.
Yeah, agencies that specialize in working with traumatized kids, like foster and adoptive kids, specialized schools, some use DDP a great deal. There's a number of practitioners in DDP now are involved with refugees who obviously have much relational trauma. What else would I say? Well, the individual DDP consultants or practitioners I know consult with legal systems, probation, parole, that people in trouble with the law, substance abuse. So it can be used. I mean, it's a model that's inclusive.
Yes, it can go from education to forensic
Right.
settings and to
It,
clinical settings to hospital
yeah,
settings.
it's based on relationships and how we're social mammals. It's
And
using that research and it can be applied to anybody
yes, yes,
having
yes.
challenge.
Any human being in any context of
Right,
human relatedness.
right.
That's so amazing. Well, that's so great. And I'm going to
Okay, Henry.
also present to the people all the books you've published. And we're happy to announce that we are publishing a second book of Dan Hughes in Spain.
Wonderful.
And everything is available in the following websites that will appear just next to this conversation.
Oh, I'm excited about this. Thanks for all you're doing,
Thank
Henry,
you. Thank
to
you.
bring DDP to Spain.
Such a great pleasure.
Mhm.
Okay. Bye bye now.
Bye now.